Good evening and welcome to this FWM panel event where we're asking the question that after the applause, we need an economy that appreciates and delivers for healthcare workers. Since the start of the COVID-19 epidemic, the nation has shown its appreciation for NHS staffs by clapping our hands and banging our saucepans every Thursday night at 8 p.m. Of course, showing appreciation is important, but this is not enough, especially for those in our healthcare services that are paid less, that are paid the least. Healthcare assistants and support workers are subject to a culture of zero-hour contracts and taking additional shifts to just make ends meet. Although their work is essential to our health services, they continue to be undervalued and underpaid. This panel will explore the policy reforms we need to change this reality and ensure that these workers are paid what they deserve. Joining us tonight, we have a full panel. We have Alastair Yap. Alastair is currently working to build partnerships with NHS hospitals to help them improve their services, make the most of technologies and build into medical devices. Prior to working in the medical devices industry, he was a senior analyst with the Boston Consulting Group and worked on healthcare policy and hospital improvement. We also have Cllr Sarah Russell. Sarah is an employment lawyer and a counselor for Northenden and a former FWM mentee. Joining us as well is Dr. Katie Omotayo, who is a GP trainee, and she is a few months from finishing her GP traineeship, and she's the founder of Mom's Bride, a platform that supports and encourages mothers from different backgrounds. She's a speaker and she's passionate about Black women and career women. We're also joined by Isha Webber. Isha read history and sociology at Warwick University, and then since then she has worked across different media platform agencies, both nationally and internationally, and speaking of various platforms on the importance of Black women's health in the UK. Just to remind our viewers tonight that you can use the Q&A functions on the Zoom to send in your questions as the panelists are speaking. And after they finish speaking, we're going to answer these questions and take the discussions further. And our hashtag for this evening is FWN EPA 50 and hashtag after the applause. Our first speaker is Alastair Yap. Alastair is a hospital solutions and partnership specialist. Alastair, over to you.
Thank you, Victoria. So I've been asked to talk about how the pay for workers in the NHS and the social care sector are assessed. And there are significant differences in how this is approached in healthcare and in social care. For the healthcare sector and the NHS in particular, the pay is guided by the Agenda for Change pay banding system, and this has been the case since about 2004. So the aim of the Agenda for Change pay grades is to harmonise pay scales and progression across professions within the NHS, with the idea being that people receive comparable pay for work of comparable complexity. Now this pay scheme covers about 1 million NHS staff, so pretty much all staff excluding doctors, dentists, and very senior managers who have slightly different pay schemes. And this was initially agreed in 2004 between unions, NHS employers, and the government of the time. It consists of bands between band 1 and band 9 with increasing salaries and multiple pay points within each band. And these are based on experience and increasing development within your role. And also within Greater London, a high cost area supplement applies up to an additional 20% of your basic salary. However, this is capped at just under £7,000. So this has been renegotiated several times since it was brought in. It was last renegotiated in June 2018 when the employers and unions agreed a 3-year pay deal. And so that will be up for renegotiation soon. And most healthcare assistants, porters, domestic service workers, the particularly lower paid members of staff will be at bands 2 and 3. So that works out to around £18,000 to £21,000 per annum for a full-time position, excluding any kind of high cost area supplements. However, there may be staff working within NHS hospitals that aren't paid in line with these agreements, and they're paid outside and employed outside of the NHS terms and conditions, and therefore are not eligible for things like the NHS pension. And this can happen where services such as facilities management and hotel services have been outsourced to other organisations. So this can be due to a trust deciding to outsource facilities management, or it may form part of a public finance initiative or PFI agreement, which is a form of public-private partnership where private organisations have contracted to complete and manage the building of NHS facilities. While this has proved somewhat controversial, they have allowed many hospitals to redevelop some of their aging facilities in the absence of available capital redevelopment funding from central government. But then moving on to the social care sector, the social care sector employs about 1.5 million people. Most social care staff are employed by small and medium-sized private providers, of which there are over 18,000. I'm going to focus mostly on adult social care, as this is the biggest sector. And the care that they can deliver can take the form of short-term care or long-term care. So short-term care is delivered by home care agencies, and they provide support to people who have been discharged from hospital most commonly, and who no longer have medical needs but might need support in looking after themselves. And there may be some overlap in terms of the services they deliver with NHS community nursing services. Long-term care, on the other hand, is delivered in care homes, residential homes, or nursing homes, depending on the needs of the individuals that are receiving this care. Again, this is a very fragmented sector, and many of the staff in both settings are employed at or close to the minimum wage. And within the sector, there is no kind of formal or national hierarchy or ranking or grading of social workers. And the median salary of these workers is around £20,000 per year for a full-time position. In this sector in particular, they have, however, benefited in recent years from the introduction of the national living wage, and the phased increase in that over the past few years has seen average care worker pay increase. However, the low rates of pay have led to quite a high level of a high vacancy rate within this sector, because they're struggling to attract people into the profession. In terms of kind of levers for reform to try to help these lower paid workers, within the healthcare sector and the NHS in particular, the agenda for change is a very powerful lever. As I said earlier, over 1 million NHS employees are paid according to this pay scale. Negotiations are due to take place in the coming months, as the current deal expires at the end of March next year. However, it's currently unclear how the ongoing COVID-19 pandemic will affect the timeline of these negotiations. It's also important to remember as well that pay currently makes up about 45% of total NHS spending. So it could be difficult for significant pay uplifts to be agreed across the board unless there's significant additional funding made available to the NHS by central government. And in social care, where we might be able to implement measures to try to increase salaries within this sector, that would largely depend on the contracting process, which could include the evaluation of factors, including pay for staff.
Thank you so much for that, Alastair, especially for highlighting the difference between the NHS system of band paying and the fact that outside of NHS, there are multiple systems used by third-party agencies, which we've seen the repercussions of that, especially when there's not one central system that they can follow, and they have more of a jurisdiction, more of a leeway of how they can pay their staff members. I forgot to introduce myself, actually. I'm Victoria Akintomide-Akinwamide, and I'm part of the FWN Exec, so I'll be your chair this evening. Our second speaker is Sarah Russell, and Sarah is an employment lawyer, and she's a counsellor for Northenden, and she's also a former FWN mentee. Sarah, over to you.
Hi, thank you very much for having me. So I am going to talk about social care in community settings this evening, so less about the NHS and more about the stuff that predominantly that is commissioned by local councils, so that, as Alastair said, is either care in people's own homes or it is going into a care home. I'm going to talk about particular problems for workers in that sector which are acute, whether that has the potential to get better or worse, and particularly how that's connected to local government finance and the problems of local government finance, and finally what we can all do to try and improve things, which I'm sure is what we're all here for. So when we talk about the sector, 83% of the staff are women, and they are 4 times as likely as the rest of the working age population to be on a 0 hours contract. They are twice as likely to die of COVID as workers in any other sector. They are disproportionately drawn from ethnic minority communities, and a significant proportion of them are parents and single parents. So it's a picture of a sector of essentially in-work poverty. The amount of money put into the sector nationally every year is absolutely enormous, and I would suggest that it is a terrible pity that the workers in it are not seeing more of it. The government is putting some extra money into local authorities at the moment to do with the COVID crisis, but to put that into some sort of perspective, Manchester City Council alone is expecting a £126 million loss of income this financial year, which equates roughly to our entire children's services budget for the whole year. We are expecting a £30 million rise in costs in the next 6 months alone, associated specifically with COVID. So far, the money that we have received from government covers about 12% of that sum, which is going to leave the most monumental hole in our finances that you could ever imagine. Councils in Greater Manchester have already lost £1.7 billion worth of funding from 2010. Manchester City Council specifically has lost £380 million and has seen our workforce reduced by 40%. Councils do not have the capacity to take any further hit to our finances. We have already done everything that was required of us in order to produce efficiency savings. There are no efficiency savings left. There haven't been for about 8 years. We took those out in like years 1 and year 2 of austerity, and now it's just cutting stuff that people fundamentally need. So when we look at the potential for the social care sector going forwards, I think there is at the moment, and this is a horrific thing to say because this is the most awful national crisis and it is absolutely terrible, and it is disproportionately impacting both ethnic minority background communities and also people from already deprived communities. So anyone who suggests that this is an opportunity, frankly, it's obscene. But what it has generated at the moment is we are seeing for the first time people paying attention to people like care workers. And Fawcett Society has just released the results of a survey that it did that said about 75% of people think that care workers should be paid more, and 65% of taxpayers would be prepared to pay more in order to see that happen. I think there has been some appetite for things to change in this sector for quite a while, actually. And I think there's the potential for there to be a unified national system of care by somehow amalgamating it with the NHS. We have a lot of care providers at the moment that are bordering on insolvent. So we essentially have 2 choices. The taxpayer is going to bail them out because you can't leave people in care homes with no care. So we can choose how we do that, and we can choose what stipulations we put in place around workers, and or we can choose to try and find ways to actually use the money to nationalise the service. I don't know whether or not the current government has the political will to do that. My suspicion would be not, but I think that's a terrible, terrible shame. And I think it is something that we should be actively campaigning for. So, but in terms of what do I think we can definitely potentially achieve, I'd just say to everyone, please could you make sure that you vote? Because local government is absolutely critical to this issue. And I'm probably preaching to the converted here, but actually the turnout in local elections is about 25%. And amongst Labour activists, I see numerous Labour activists who come out and help in general elections, which is deeply, deeply appreciated, but they don't come and help in local elections because people think that local government is dull. And local government isn't dull. Local government is absolutely critical to all of these issues. So what I'd say is, please come and, please stand, because actually there's a reason that Labour councillors are absolutely at the forefront of living wage accreditation, and there are about 70 living wage accredited councils across the UK. And it reads like a who's who of major Labour boroughs, basically. And the knock-on effect of those living wage accreditations is that these very poorly paid workforces, through our commissioning arrangements, become much better paid, and also are much less likely to be on 0 hours contracts, because there's an enormous penalty that you pay for being on a 0 hours contract in terms of your ability to arrange childcare, your ability to plan for the month. So I think we need to make sure the conversation isn't just about hourly pay rates, it's also about stability of employment and associated benefits. So I say, please go along, support your local councillors, ask your local council what they are doing about the living wage, understand that at the moment they may actually be terrified about their financial survival, but we still have to ask questions about this stuff, because that's the only way change is going to happen. Okay, thank you very much.
Thank you very much, Sarah. I love the points you emphasize about the national unification of care homes and making sure everyone come underneath the same umbrella. And just to refer back to one of the points Alastair made about the services being done by third-party providers, and often these third-party providers would then have their own jurisdiction of how they're operating. Whereas if we have a unification of this, like you mentioned, we would have a strong oversight on how they're operating and how they're paying their staffs as well. So that would be something that I would definitely be thinking about in terms of actual policy change moving forward. Just to remind our viewers to tweet and send in your questions as well to using the QA box on your Zoom. And then moving on to our next speaker is Dr. Katie Omotayo. She's a trainee GP and she's also a campaigner. Katie, over to you.
Thank you very much for having me, and thank you very much for actually having this discussion. As a GP doctor who's been practicing for about 5 years, I've actually been in contact with healthcare providers since I was in medical school. So altogether making 15 years since we've had that kind of relationship with them. So what I did want to highlight today was the importance of all healthcare workers, and also highlight the difficulties and the disparities, which Alastair and Sarah have already mentioned on. So starting from what do they add to the healthcare? First of all, who are healthcare professionals? Who are their providers? They are all the key workers that are supporting the healthcare system in general. So that is not just the doctors, because that's what the first thing that people think of. It's not just the doctors or the nurses, it's actually the healthcare assistants, is the physician assistants, is the porters, is everybody, the cleaners, all of them are actually healthcare providers. You cannot actually have a successful system without having the foundation. Now, why is the foundation so much disregarded is what we need to talk about. Why are they so underpaid is what we need to find out. So these are the things that we need to be thinking of when we're thinking of clapping for the NHS as well. Who are you actually clapping for and why? And are you in particular clapping for one particular area or the other, and why so? So these are the things that I like to really bring up and, you know, start talking as a group as well. So what do they add on? Well, like I said, they are the foundation and they are the support. So they, you know, when you enter a hospital and you can step on the ground, who actually clean the ground? Who actually cares for people after the doctors that have written the different kind of treatments. We always say that we would not be here if it wasn't for the healthcare professionals. You know, in my family, we have healthcare professionals, and people don't really pay them attention because it's not a glorified job. You know, they don't wear such a big hat, or they have a title in front of their name. And these are the kind of things that we want to stop. Having said that, we also shouldn't think that everybody is just one side, or everybody's just fulfilling a certain role. And one thing that I have experienced, and many other people will have experienced, is the racial disparities as well. So because you look a certain way, you're most likely going to be this rather than that. Why do we think that? Why are you already having that judgment, which we know it comes from somewhere? We know that this is how things have been progressing, but we are now here to change that. There's lots of doctors that look differently. There's lots of nurses that look differently. There's lots of porters that are young, old, and from different kind of race. So that leads me to the next thing is, why don't we see them out in the mainstream? Why don't we see them on the social media? Why don't we see them in the movies even? You know, why do we focus so much on, I'm not trying to minimize doctors, nurses, consultants, and everything else, because they're good at what they do. But what we are trying to bring is equality, not just between men and women, but also between different kind of roles, when they're all as equally as important, because you can't stand at the top if your foundation is not strong enough. So what can be done to bring them out in the open, I think, is conversations like this. Talk about it. Find out what it's like to be a porter. What do they do? How long do they work? Really and truly, they're still there working when the big boys at the top are leaving. You know, what does it entail? How is their shift work? We were talking about the zero contract, for example. Why would they want to go for that rather than something else? We were talking about other systems that are outside of the NHS. There's many private social care agencies. Why would I, as a woman or as a person from a minority origin, why would I prefer going to a private company than a public one? And that's because of what they offer. We need to think about what is offered to them. So even for them to be shown in the mainstream, what are we offering them as a thank you, or as a, what are we giving back to them for them to want to show themselves? If they're used to being suppressed, they don't have much of a reason to fight to come out. Because like I said, they're already struggling to do what they want to do to have the best quality of life, because that's what it's all about. Everybody should be able to reach to an equal quality of life despite of your job role. And that leads me to the last question, which is, what can we do as other staff members? What can we do to help them raise them up? And I think it starts from the smallest things, like thank you. Just appreciating them. How many people have been to the hospital and said thank you to the person standing on the door? We have welcoming team. We have porters. We have cleaners. They just look so invisible in care homes, in GP centers, in different places. They look so invisible, and they figured out that there's nothing else they can do because no one values their job as much as they do, to the point that themselves won't even want to achieve more if they had the opportunity given to them. Because I do know that a lot of people are asking, why don't they go for higher paid jobs? Well, if they don't feel like they belong there, why would they go for it? So these are the kind of conversations, these are the kind of questions that I really want to bring to the forefront, because they're very important, and this is how we will then get to a change. Thank you.
Thank you so much, Katie. I love the points that you made about equality between roles, and that line about you can't stand at the top if your foundation isn't strong. If the foundation of the hospitals and if the doctors and the nurses and the surgeons don't have the people that are ensuring that they're able to do their job, whatever they're doing is just not going to happen. And that's something important that we need to not only remember now during this crisis, but to take forward as we reform our healthcare services, that these are the people that are actually ensuring that we're able to get the services that we do have. Our next speaker is Isha Webber. Isha is a researcher and a campaigner. She speaks on various platforms about issues facing BAME women and women's health particularly. Isha, over to you.
Oh, hello.
Hi.
Can you hear me? Okay,
Yes,
great. Sorry. Okay, guys. So the first question, who are these women? So these women are mothers, sisters, grandmothers, wives, girlfriends, cousins, aunties, acquaintances, colleagues, community pillars and leaders. They are, as Sarah mentioned, sometimes the main or the sole breadwinner. They are refugees. These are migrant women who have come and sought a better quality of life. Some of them had professions in previous countries, and due to immigration issues or the immigration system, humbly retrained. In my opinion, and as we all know, they are descendants of royalty and of people who had a lot of indigenous knowledge and practices. However, the reason why a lot of these women find themselves juggling multiple shifts, both within the NHS and with the private healthcare providers, is to provide not only for their immediate family, but for family members in their countries of origin. So there has been a conversation about the impact of wages in terms of what remittances people in Asian, African, and Caribbean countries will receive from those who work here. As of Saturday, it was reported that 183 of those in the health and social care industry have lost their lives from contracting this virus. Many of their families have actually set up GoFundMe pages, which I think is very telling of the precarious nature of the industry. So to pay homage in line with the Say Her Name movement that was started by the African American Policy Forum in 2015, I would like to honor some of these women. So Carol was a care worker, 56 years old, and she was the first woman who was identified publicly. She was a care worker at the Cherish Elderly Care Centre in Manchester. Filipino nurse, Rezi, was 64 years old and she worked in Merseyside. Onyaka was a nurse and a healthcare worker and she lived in Barking and Dagenham. Jenny was a hematology nurse and she trained in the Philippines before joining UCL in 2002. Leanne was a care home worker at Mumbles Nursing Home. Efwa was a healthcare assistant. Grace was a healthcare worker. Gladys was a mental health nurse in Derby, and she actually had underlying health conditions and she stepped away from work before the virus had spread. Rahima was a care home staff member in Sutton for over 3 decades. And Mary, who we have all known about, was a pregnant nurse, 28 years old, who worked in the general ward at Luton University Hospital, and she was working there for 5 years. Maureen was a healthcare assistant, 60 years old, in Bristol, and she had worked in the NHS for over 25 years. So the impact of low pay on these Black and brown women include sleep deprivation, imbalanced circadian rhythm, inability, as Sarah mentioned, to attend crucial meetings at their children's schools, poor diets, housing insecurity, no time or lack of paid leave to attend their own healthcare checks at the GP, prejudice, microaggressions, discrimination, systematic institutional racism, the danger to their personal safety as they travel unsociable hours to get to and from work, job insecurity, which leads to stress and anxiety, and we know this has a high correlation with underlying conditions such as hypertension, diabetes, and cholesterol, and lack of career progression. So in the unfortunate case of Mary, who lost her life whilst pregnant, my question is, why was she made to work during the last trimester of her pregnancy? Why was she not seen as exempt from the emerging shielding protocol? And why didn't her line management use common sense and compassion to give her a full paid
So we couldn't get the last part of that. If you could say that again. We couldn't hear the last few minutes of those. We couldn't hear the audio. So if you unmute yourself.
Hello?
Yeah.
Can you hear me? Sorry.
Yes, we can hear you there. If you don't mind going through what you just said again, please.
Okay, the systematic changes needed for these women include dismantling the imperialist, white, supremacist, capitalist, patriarchal system, which has dehumanized non-white women for centuries and now underpays them and has been reckless without protecting their lives. The introduction of grants and living stipend in line with the London living wage as a minimum, regardless of where these women lived in the UK, for those who want to go into this line of work. For women to receive education from a curriculum that doesn't dehumanize them, regardless of their immigration status, and the eradication of zero-hour contracts in this sector to safeguard these women in these communities.
Thank you very much. I think I love the way you listed out the name of the women that have lost their lives during this epidemic. I think it's important to put a name to a statistic so that people's lives and people's stories aren't just part of a front page, because these are people's mothers, these are people's sisters, and they are doing a public service and they should have been protected so efficiently, instead of being reduced to not only having the right equipment but losing their lives as well by just doing their jobs. So at this part of the panel, we're going to move to the questions for the panelists. The viewers have been sending in some questions, and I'm going to direct those questions to the panelists. Our first question is from Favor, and she's asked that it does appear that care workers are not regarded as professionals, hence the poor wages and the working conditions. How do we professionalize the care work industry? Alastair, do you want to give this a shot?
Sure. So in comparison to nursing, you don't need a degree to go into social care. And that can lead to people seeing that as a less prestigious career. The career prospects aren't as certain. And because the pay rates are so low, there's a very high turnover of staff within the social care sector. Something like 30 to 40% of staff will leave the social care sector in any given year. And unless something is done to professionalize and provide a long-term career pathway for staff, this will continue for the long term. And when you look at the male-female split as you move up within the social care organizations, the proportion of women in senior roles compared to the proportion of women in direct patient-facing roles is much, much smaller. So you have 86% of women delivering direct care to patients and clients. But when you look at the senior levels at management, that reduces down to 60-something%. So you have over a third of men in senior roles, when it comes to delivering direct care, it's less than 20% of men that are actually delivering the care.
Okay, and so how do we then ensure that, let's say I'm a sixth form student back in the day, flashback, and I want to decide my career progression. How do I make sure that being a support worker in a hospital is as great as a career prospect as being a doctor like Katie? How do we make that profession more appealing to young people coming up?
So I think some of it might be through providing an alternative route into, say, managerial roles within the NHS, through doing almost like an apprenticeship. So you start off as, say, a cleaner, and then you get opportunities as you gain more experience. to progress up the pay bands. That's the way that these pay bands were designed. However, if the pay rates remain low and the progression up between the pay grades aren't so great, then it becomes less of an attractive long-term career for people, particularly when they are putting themselves at potential risk of catching contagious diseases and, you know, putting their families at risk, as we're seeing in the current COVID-19 pandemic.
Thank you very much for that. There's a question that relates to that, which I would like to direct to Sarah, on this subject of unskilled worker within the care sector. And there's a question about the statements that care work requires and uses incredible complex skills, and for too long it's been dismissed as unskilled. Can you just comment on that, Sarah?
Well, I always think two things about that. One is, even if it was, I don't accept that it is, but even if it was, if you get out of bed every morning and you do a decent day's work, you should be paid a decent day's pay for that you can actually live on. It's not acceptable that 36% of children are growing up in poverty, and the majority of them are growing up in poverty in working households. So there is something specifically here about how we value care work, and particularly work that is predominantly female and disproportionately Black and minority ethnic. But there is also something here about fundamentally, how do we value work? Why should people go hungry if they have a job? In fact, why should people go hungry, full stop? But to take that sort of specific point about skilling, it's not low skilled work. And that tends to be the way that people talk about work that's predominantly done by women. It's the reason that teachers are paid less than doctors. They're both really highly skilled professions, but we value one of them significantly more than the other. I'm not sure that that's really reasonable. I mean, and this is about the 50th anniversary of the Equal Pay Act. And what the Equal Pay Act has never delivered and is not going to deliver is pay equality for predominantly female professions where it is becoming increasingly difficult to find useful male comparators. So I think that, you know, yes, it should be treated as skilled work, but even if it wasn't.
I mean, absolutely. I mean, the idea that someone doing something that adds value to our society in and of itself as unskilled is just a very backward way of thinking. There's a question here from Catherine as well. It touches on the agenda for change model. So she suggested a framework outlining skills against pay band with a clear career pathway and genuine opportunities for training. So that's the policy she's been thinking about. Katie, as a doctor, how have you seen this pay band framework work within the profession? And do you think this idea of having a clear agenda, a clear band framework for people coming through the system actually works in terms of like leveling out the pays between different bands?
Well, I think having a structure is important for any kind of industry. The problem is when the structure itself is flawed, and when what the flaw itself is, what is your aim? Do you really want a lot of women in that kind of job? That is the question, really and truly. Who actually creates the structure itself? So I think what hasn't worked is the people that are creating the structure. That's not worked. The way that the template has not worked. I've had conversations with different healthcare professionals who are actually, and also the managers in the NHS, talking about how they are deciding how the money is spent, for example. There's always an aim. Okay, just like a business module, you need to have an aim and objective. What do you want to get out of this and why? Who is it really going to benefit? So I think if we do want to bring up more, I don't want to call them lower skilled, just a different kind of skilled and unfortunately lower paid kind of roles, we do need to present them in the same way we present a medical one. Now, yes, we do have different pathways, and I you know, I will not pretend to be an expert in terms of how you decide how much someone needs to get paid. But what I do know from experience, from speaking to people and research, is that once you see something as low and as you did not spend that many years in uni to get there, then it's seen as low skilled, because you would call an entrepreneur low skilled as well, because it didn't go to university and didn't get their degrees to get to where they want to get to. You know, whoever funded all the things that we are using from day to day, they didn't need a university degree to get there. Still, they used so many skills that they have learned. What about coding? Coding itself, people don't even talk about that. That is a huge skill itself. Organizational skills, like if you think of how you write your CV and you want to write all the different qualities that you've got and you want to set them up with your experience, that is what makes the role. That is what makes you worthy to be paid enough for your time. So I think it needs to go back to the structure. Who makes the structure? Let's have some more women standing and sitting on those panels that make those decisions. Because as much as you're going to have a panel full of men deciding things, it will always be flawed.
I completely agree. The feminist in me was like, yes. We have another question in terms of policy and moving forward on this agenda. So the question is from Emily: what should our short-term and long-term campaign on this issue look like? Aisha, I would like you to touch on this, specifically on the area that the fact that a lot of these roles are carried out by women of color, by BAME women. When we're campaigning on specifically on issues that is affecting women of color, what is our short-term and long-term strategies? What should that look like?
So in terms of a longer term strategy, I definitely feel there needs to be a review of how we, particularly within the NHS and other sectors, go about the whole appraisal and peer review process, which was actually one of my points before the phone did its thing. So this whole notion of unconscious bias and who gets promoted and who doesn't. Looking at the women who unfortunately lost their lives during this pandemic, many of them are staff nurses or healthcare assistants, but they've worked in the industry for 20, 30 years. So what is happening in terms of progression? As Katie mentioned, who are those who are making the decisions at the top? Alastair alluded to the percentages of decision makers, those in senior management. So if somebody in any other sector, you wouldn't have a student doctor in the same role for 20 years. There is a career progression. So that's something that needs to be implemented, because also comparatively, if you look at, and I don't like to use the term, if you look at BAME women in comparison to year on year, pound for pound, in comparison to their white British counterparts, BAME women are getting paid significantly less, which means that you create this cycle of taking up multiple 0-hour contracts. As different panelists alluded to, the average salary being 20,000. If you live in zone 2 or zone 3, or in one of the major cities in this country, how far is that going to get you? And you tend to be a mother, and you tend to be most likely the sole breadwinner of the household. So in terms of long-term, short-term, the whole process needs an overhaul. The whole system needs an overhaul. In my opinion, the whole system has been set up to keep the disadvantaged and to prop up the system and to maintain that foundation so those at the top can continue to progress and to have access and social capital, which they then replicate. Going back to the question about how does one think of going into the social and healthcare sector, I think we need to, as Katie mentioned, it's about representation. It's about a curriculum all the way from medical school, all the way up, that doesn't make you feel as though you are an alien or you're barbaric or you are anything less than. We're looking at, I'm very passionate about health disparities. If we look at the cumulative effects of the health disparities between those people who are from BAME communities who have died disproportionately in this pandemic, we have got so many issues to address that I don't think just fit in terms of contracts and how much somebody is paid every month.
Thank you so much for highlighting that just the massive issue, especially how this pandemic is affecting women and women of color. I want to touch on government policy. So there's a question from Moses. He mentioned that Sarah mentioned that 65% of taxpayers are willing to pay more for care and support workers. And then Alastair mentioned that 45% of NHS budget goes unpaid. So the question is, if taxpayers are asked to pay more, how do we then best hold the government and NHS trusts accountable in making sure that the extra funds goes to increasing pay for care and support workers? If we're pumping more money into that system, how do we then hold them accountable to ensure that the money is going to the payments, it's going towards good salaries for these workers? Alastair, do you want to give that a shot?
Sure. Well, as things stand, the health and social care sector in the long term is frankly not that sustainable. Part of the reason that the social care sector has increasingly privatized over the last 30 or 40 years is that they're able to pay lower salaries than public sector providers of social care. In terms of the NHS, we know that we have an aging population, and with that, we will have increasing demands for healthcare services. We're getting to the point, I think, where we might have to start a national conversation about what we want out of our national health service and how much we're willing to pay for it. And to Moses's point about ensuring that any additional revenues are directed towards health and social care, I think the best way to do that would be to have a separate tax, insurance, whatever you want to call it, maybe an NHS levy that is ring-fenced for paying for health and social care services. Whether there's political appetite for that, both within any of the major political parties or within the electorate more widely, is not a question that I can answer right now, but it is certainly something that could be thought about.
Sarah, on a local government level, is it possible to further ring fence funds for social services, specifically healthcare services? I know there's a specific budget to it, but then, of course, every year the council needs to renegotiate their budget. But moving forward, is it possible to then ensure that those funds do not get touched at all?
So at the moment, social care is a statutory service, so we have statutory obligations for what we're obliged to provide. The government would have to intervene to change the law to make councils provide money at a set level. And or there is obviously also private providers in the market, so there are people buying their care individually. And I think one of the things that could potentially appeal to the Tories is at the moment things like you can look up a CQC report on your local care home, but it doesn't tell you anything about staff wages. It tells you about whether or not all the staff have a DBS check. I don't see any reason on why it would really cost any more for the CQC to start asking some questions about percentage of agency staff, about staff turnover, and about the percentage of staff who are paid the living wage, and then that information could be publicly provided. Now, do I think that's an across-the-board solution? No. Do I think it's adequate? No. Do I think the Tories might go for it? Yeah.
Because it will show that they're caring, that they are looking after communities, which is a good PR ploy. But anyways, it's the Tories. There's a question from Sarah Russell. Apologies. And the question is, it would be fantastic to see a unified national care system that uplifts the staffs that are often marginalized and provides them with opportunities for development. What can we do to ensure that such a system is created rather than the replication of the privatization system that we currently have? So how can we have a system that uplifts and develops the workers within it rather than the current focus on privatization? Sarah, do you want to give that a shot?
So I think it's very striking that I've kind of advocated for a nationalised service as something that would potentially improve the conditions for workers. but that actually the other panellists have pointed out, I think very eloquently, that actually the structures within the NHS leave a great deal to be desired, and a great deal to be desired, you know, particularly for women and women of colour. So I suppose I feel that I've advocated something that is only a partial solution, but I suppose not to make the perfect the enemy of the good. I do think it has a lot of potential, and I think the government might conceivably buy it, but it needs a campaign that is run by trade unions that gets workers' voices out there and makes it really clear to people in influential places actually how difficult it is to live on less than the living wage.
Yeah, absolutely.
Also, it stresses the benefits as well to the people who receive the care, because I do think there are huge benefits to having people looking after you who are not stressed out of their mind about money and their insecurity.
Yeah, absolutely. There's another question from Kelly here, which I'm going to address to Katie. And it says, as Cllr for carers, although well-meaning, actually allow the government to avoid scrutiny of the way carers are treated in terms of their pay and conditions, as it provides a kind of cover to pretend that they are being appreciated. So this clapping every Thursday night that we do, has it allowed the public to just think the government is doing enough?
Well, I think the people that truly care about the NHS will understand that the clap can be seen as a cover. I'm not going to lie, when the first time clapping, I felt good. I felt appreciated. It's true, and I'm keeping it like really real with you. The fact that someone was clapping, and it made me feel appreciated for the job I'm doing, because even as a GP, I am a Black woman. So I do face my own obstacles in the system itself. So to feel like someone actually cared for me made me feel good for a minute. Week 1 went by, 2, 3. After that, I was tired. I'm not going to lie. It does cover up a lot of things, but it's not, I don't want to make it sound like it's just a cover like that. It's everybody covering it, because now everybody's clapping, but they're still not following social distancing. They're still not following the guidelines. And I am pretty sure that a lot of people after this will go back to do the same thing they were doing. Now, if we want to look at it from the bird's eye view, yes, the government, everything that we are seeing, everything we are hearing has been pre-planned. It's just like watching the TV and feeling like you want to buy what's been advertised. Believe me, there was years and years of research from people saying, I want that person to feel this way once they see this advert. So that's the same thing with all the different hashtags that are going on nowadays. However you're feeling, believe that that's exactly what they wanted you to feel. So you need to have that overview of things and then take yourself out of it and think, how do I actually want to feel? How do I feel about it? Why am I clapping for the NHS? What have they done for me? What have they not done for me? What have we done for them? You know, lots has changed even in our practice, even as GPs. And every time we get clapped, we think, but they don't. I'm so happy, actually. One thing that has come up from this is that a lot of people are talking about things. A lot of people are talking about the disparities. A lot of people are talking about how Black and Asian women and minority ethnic people are at risk, are dying, are not spoken about, are not appreciated. Because there's no point, it's just like going to church on a Sunday and then on a Monday you're going back to doing evil stuff. So why are you looking good for a minute? Let that be your lifestyle. If you're clapping for the NHS, let that be your lifestyle.
Absolutely. I love that you can't just do this for the short term because everyone else is doing it because it looks good, whereas we need long-term systematic change that actually goes to the root of the problem. Our final question is a bit of a question / comment. This is from Katie Webber, and this is for Isha. And it says, thanks, Isha, for stating the names of just a tiny amount of these women who have made the supreme sacrifice. Maureen Ellington from Bristol was the much-loved aunt of my teammate. And remembering these are all people with families, aspirations, dreams, is so important and poignant. Beyond remembering these women, what else can we do to change the narrative about who really keeps our nation going and to whom we all owe an enormous debt of gratitude and a fair pay, respect, and genuine equal opportunities?
Wow. Oh, we have the same surname as well, so that's coincidental and sweet. Oh, I'll be honest, looking through the list that was provided, I think on Care Homes UK, they compiled a list. That was quite emotional because there are a lot of pictures, and I had to cut it out because of time, but mentioning how many children they had, how long they'd been in this country, their favourite sport, or their favourite food. Going forward long term, I'm a big advocate of community-based appreciation. So what we can do going forward within our own small communities is remembering those women who were working on what has been dubbed the front line, even though I don't like that term, and creating more community care, hospitality, keeping what has been cultivated during this lockdown period going. That's what will make the difference. As Sarah alluded to before, getting in touch with your local councillor, signing petitions, finding out what is actually going on in the health and social care sector where you live, and joining the picket lines, advocating, and creating stable structures on a more, as I said, community-based level, being a listening ear to these women, being a support system for these women. Many of them are not being paid as much as they should be. So whether it's cooking a warm meal, taking their kids to the park when we're allowed to go out, and just building a support system where they don't feel they're so alone. Also cultivating a culture of leisure. Pleasure is a form of activism. You know, self-care is a radical form of activism, as Audre Lorde did say. So cultivating this culture of rest where, you know, you don't have to always take that extra shift, or you don't have to feel compelled, and actually having the difficult conversation, you know, talking about money, nobody really likes it, particularly women, and then British culture, stiff upper lip, which obviously I have thrown the shackles off. So that's more what I think. And, you know, whatever your heart prompts you to do, Katie, then you go ahead and you do that.
Thank you so much for that, and thank you to all of our panelists as well, and thank you for everyone that have sent in questions. I think one thing that I'm taking away from today is definitely to use my voice, to campaign, to petition, to ask questions of my counselors. Appreciate the receptionist at my GP surgery, and understand that it's not just my GP or my surgeon that is ensuring that I'm able to get the healthcare services that I am getting, but it's actually everyone within the healthcare system that is putting in the work. And this event was part of the FWN celebration of the 50 years of the Equal Pay Act, and we wanted to highlight the women that are within our workforce that aren't appreciated, that aren't working, that aren't given the spotlight that they do deserve. Again, I'd like to thank the panelists for joining us and for the questions that everyone has submitted. Please do follow FWN to find out more about the things that we are doing. We're available on all the social media platforms, and we have a great mentoring program for women that want to get involved in politics, that want to get involved in policy. So if you're a young woman or woman out of any age, that you have a voice and you want to learn how to make a change in society, find out about FWN. I'd like to thank our panelists again for joining us this evening, and that is the end of our panel this evening. Thank you very much, everyone, for joining us. Have a great evening.